to travel, journey, voyage, expedition, tour, pilgrimage, safari, odyssey, to boldly go where no one has gone before.
Welcome to our podcast, Travel Unravelled, an ISTM podcast sponsored by the International Society of Travel Medicine and IAMAT, the International Association for Medical Assistance to Travelers.
So welcome back to Travel Unravelled, where we explore the latest developments, challenges, and innovations in travel health and medicine. I'm Dr. Aisha Khatib, the ISTM podcast director. In this episode, we slither into a topic that's as deadly as it is overlooked, snake bites. As we mark the year of the snake in the Chinese zodiac lunar calendar, it's the perfect time to shed light on one of the world's most unappreciated public health threats. Former United Nations Secretary General Kofi Annan once called snakebite the most neglected tropical disease you've never heard of, and for good reason. Despite killing over 100,000 people annually and leaving many more with permanent disfigurements and disabilities, snakebite envenomation remains dangerously underfunded and misunderstood. From Southeast Asia to sub-Saharan Africa, from rainforest trails to desert treks, travelers and clinicians alike need to know the risks, realities, and remedies. So in the spirit of the snake, let's unravel the facts, shed the myths, trace its deadly path across the continents, and ask why this ancient threat still hides in the shadows of global and travel health. Here today with our hosts, Dr. Albie de Frey and Dr. Sarah McGuinness. Hi, Albie. Hi, Sarah.
Hi, Aisha.
Hi, Aisha.
Albie's joining us today from Funchal, Madeira.
Funchal?
Funchal.
Now follow Portuguese. Neither do I, but it's Funchal.
I'm a travel doctor after all. And Sarah is joining us from Melbourne, Australia. And they both live in parts of the world where snakes are part of the normal fauna. We do have a few here in Canada, but they're as polite as Canadians can get, that's for sure. How are you guys doing today?
I'm still on the not on the African continent, but on the African tectonic plate. But I decided it seemed winter is approaching in Johannesburg as well. It's time to move a little bit further north, where interestingly enough, and I might be corrected by the boffins with us today, but there are no indigenous snakes. It's a volcanic island, and so it's a wonderful place to go hiking. Nothing's going to bite you in the heel in biblical fashion. There's been recordings of the odd introduced snake, but they certainly haven't settled in here. So perfectly safe and sort of the wrong place to speak about snakes from.
I'm pretty jealous that you've moved to warmer climes there, Albie. Here in Melbourne, it's getting into the colder months, and you'll notice from my jumper, we've certainly started to feel the cold. But my parents who live in coastal New South Wales had a snake in their driveway the other day. So they're certainly active in other parts of the country, but snake activity tends to peak in the warmer months here. So that usually for us is September to April. So we're just getting into the colder part of our season where sightings are less common.
Sarah, it's one of the reasons I moved to New Zealand and not Australia when I had the opportunity.
Yeah, less animals that can kill you.
True. So I would like to introduce today our guests for this very exciting episode, and we are very honored to have two of the world's leading snake experts, Dr. Professor David Warrell and Professor Bart Currie. Professor David Warrell, one of the world's leading figures in tropical medicine, is Emeritus Professor of Tropical Medicine and formerly head of the Nuffield Department of Clinical Medicine, University of Oxford. He is the founding director of the Centre for Tropical Medicine in Thailand and is widely regarded as one of the foremost authorities on snakebite and venoming. His research has focused on the incidence, morbidity, and mortality of snakebites across Africa, Asia, Oceania, and Latin America, and he has been instrumental in developing and clinically testing new antivenoms, notably for saw-scaled viper bites in Nigeria and taipan bites in Papua New Guinea. His work has been pivotal in recognizing snakebite as a neglected tropical disease in the World Health Organization's list of priority neglected tropical diseases. In recognition of his services to global health research and clinical practice, Sir Professor Warrell was appointed Knight Commander of the Order of St. Michael and St. George in the 2022 Queen's Birthday Honours. So welcome, Professor Warrell.
Thank you very much, Aisha. That's far too flattering. I think anyone in the field of snakebite will realize there's so much unknown that we're all just struggling to achieve as much experience and as much clarity as we can. I don't think any of us would regard ourselves as experts or supremely knowledgeable. We're just struggling for greater awareness of the problem and how it might be dealt with.
And Professor Bart Currie, he's based in Darwin, Australia. He's an infectious diseases and public health physician at Royal Darwin Hospital and professor in medicine at the Northern Territory Medical Program. He leads the tropical and emerging infectious diseases team at Menzies School of Health Research, where he began the Darwin prospective snakebite study 35 years ago. He is an expert in the medical treatment of venomous creatures, and he even has a jellyfish named after him. So, Professor Currie, welcome.
Thank you, Aisha. Thank you very much. So it is actually an enormous pleasure and privilege to be joining you all, but particularly with David. David, since you were knighted, I thought it should really actually be, in addition, the Order of St. Patrick as well, because, of course, David has done more for snakes and snakebite management in the world than pretty much anyone, I think, and I've learned so much from him over the years. And my area of knowledge, it really is restricted to Australia and Papua New Guinea, whereas David has travelled the world to everywhere where there are snake bites and helped people in so many different parts of the world. So his understanding of the global diversity of snakes and what they do to people and also how to treat them is unprecedented. It's great to be able to share this with David as well.
Bart is far too modest about his own contributions. And in fact, Bart and I share a dual interest in, particularly in infectious diseases and tropical diseases, but also all things venomous. But over the years, I've learned an enormous amount from interacting with Bart, both in person and by correspondence. We've had a very good correspondence on all manner of topics. So great to be on this session with you, Bart.
Isn't there a story about you being given antivenom by one of your colleagues, David? Am I allowed to talk about that, or is that off the record?
I'm a bit embarrassed, but yes, I was bitten on 2 occasions milking snakes. And frankly, you can't learn much about the pathophysiology of snakebite without getting the snake's venom and studying it in the laboratory. So I had to acquire the skill, or not, in my case, not so much skill as I needed, of finding and capturing, keeping in captivity and milking of their venom, some venomous snakes. And I'm ashamed to say that on 2 occasions I was bitten while milking, and unfortunately I chose 2 of the most dangerous snakes, the West African saw-scale viper, Echis romani, and the Burmese Russell's viper, Deboia siamensis. So it was bad choice and it was lack of skill, and I'm very embarrassed about it. And I would never have mentioned it, but it takes a real friend like Bart to bring up these sort of defamatory things right at the start of a podcast.
But
You know, one of the things is not so much as the love of snakes, but I think more so of the fear of snakes. And it's one of the most common phobias that we see. And let's be honest, it's not completely irrational, although some people don't have as much fear to perhaps milk a venomous snake. But we see this in mythology and movies, and that snake encounters generally have been portrayed to be quite dangerous and to be quite scary.
And I know we do have a fearsome reputation when it comes to snakes and other dangerous creatures. You know, we're home to some of the world's most venomous snakes and also dangerous creatures of all other kinds. And, you know, Bart's a fan of crocodiles. But while we're home to some of the most venomous snakes, fatalities in Australia are pretty rare. There's only really about 2 or 3 cases a year. And that's really thanks to public awareness, good first aid, access to medical care and effective treatment, including when it's needed, antivenom. And it's not to say people don't get bitten here. You know, certainly people do get bitten, including travellers. For instance, in 2023, there was a British tourist who survived a bite on Kagari, Fraser Island. And there was a French backpacker who tragically died after a bite at a rural Victorian property during a working holiday. So snake bites are a real problem, although perhaps not as big a problem in Australia as people might think.
Well, Sarah, maybe that's because Australia is not exactly classified as a developing country, and snakebite has been identified by the World Health Organization as a neglected tropical disease, which of course neglected tropical diseases by default mostly affect tropical countries, which unfortunately is also mostly the developing countries. And unlike some of the other neglected tropical diseases where there's some hope of eradicating this or that infection, we can't say the same for snakebite, because we can't eradicate all the snakes in the world. We'll get some protest from at least 2 gentlemen in this group. The WHO have set up programs where you've mentioned it. The first thing is education, really, is to teach people to stay away from snakes, Professor Warrell. Dr. Bart, apart from education, the WHO is really trying to make effective antivenom more accessible to people in the countries that are most affected. But I've had the privilege of having a rinkels in my kitchen on one occasion, and in a spate of about 6 months, we had no less than 7 rinkels traipsing through the garden or through the neighbor's garden, so there must have been a nest somewhere. And of course, rinkels is neurotoxic. Luckily, nothing got bitten. So we've got our fair share of snakes, even in urban areas. But by and large, snake bite in travelers, in my experience on the African continent, I've only dealt with about 3 over a period of 30 years. And one of them was in one of my paramedics who fancied himself to be a snake expert, hauled a snake out from under a containerized office somewhere in West Africa, and then walked around with a snake draped around his arm, showing it off. He got bitten. His wife, which was a medic, also decided to give him antivenom. Now, a very tricky situation. Because he knows snakes, he knew the symptoms to expect. And of course, he got the symptoms. So it was very difficult to advise whether they should or not give him polyvalent antivenom, which he did. And the consequence of that was that we had to fly him out a couple of days later because he suffered some kidney damage in the process. He developed serum sickness, for lack of a better word. But that was the worst side effect he had. Other than that, we've only ever administered polyvalent antivenom to an Angolan guy that went hunting for rats and stuck his arm into a termite mound hole and pulled out a black mamba on the wrong end. And he was clearly suffering neurotoxicity, had to be intubated, received polyvalent, which we had in the camp, and he survived that.
So I'd like to throw it back to maybe Bart and David, as Albie was throwing around some words about neurotoxicity and antivenom. And I think for our listeners, they might not know the differentiating characteristics between snakes. So perhaps David and Bart could enlighten us a little bit about some of these symptoms and syndromes that Albie has mentioned. But also, it'd be great to hear your thoughts on why do you think snakes are perceived as such a threat, and especially in travelers?
David maybe has brilliant summaries of the different properties of venoms, which are composed of many different proteins, and each snake genus and then species within a genus has a constellation of components which can then lead to a clinical syndrome that is specific usually for that species. David, maybe be very happy to hear you again summarize the different components, please.
Yes, I'd be happy to. A simplification of this very complex mixture of proteins and polypeptides that constitute snake venoms. By the way, it's not a single poison like strychnine or arsenic. It's a highly complex, highly evolved mixture, perhaps 100 different compounds. The key actions as far as the human snakebite victim are concerned, first of all, would be causing shock of disastrous fall in blood pressure by various mechanisms. Secondly, a disorder of blood clotting, so that people start to bleed spontaneously and sometimes fatally into their brain or gut or elsewhere. This is due to damage to blood vessel walls, but also various actions on the blood that makes it incoagulable. So the venom will destroy clotting factors and will inactivate blood platelets, which are involved in this process of controlling bleeding after injury. A third important effect, which you've heard mentioned already, is paralysis or neurotoxicity, which starts with the eyelids and spreads downwards for unknown reasons, eventually affecting the muscles that protect one's airway, so that there may be danger there from inhaling vomit and so on, but ultimately paralyzing the breathing muscles, so the person can't breathe and goes into respiratory failure. Some venoms also damage muscle, not only locally at the site of the bite, but generally producing very severe effects, particularly on the kidney when the muscle proteins dissolve into the blood and are filtered through the kidney. And some snake venoms cause damage to the kidney, acute kidney injury, again by various different mechanisms. I mean, nothing is simple in snakebite. It's rare that you can attribute one effect to a particular toxin. But we know that some of these proteins are enzymes. They activate reactions. So in the case of the blood clotting problems, they will promote blood clotting, and the clot is immediately destroyed by the body's own system of breaking down clots. And eventually that will exhaust the liver's ability to maintain levels of blood clotting proteins. And the action of some of the neurotoxins are very well understood, either damaging the ends of nerve terminals or competing for binding of the physiological transmitter. Either way, the problem is paralysis, spreading paralysis. Various methods of lowering the blood pressure, one of which has been turned to very good advantage, by the way. I don't know how many tens of millions of people in the world are taking ACE inhibitors and angiotensin converting enzyme inhibitors, not only for blood pressure, but also to protect themselves from various other cardiovascular disasters. But these ACE inhibitors, their structure is based on a toxin from the venom of a Brazilian snake called the jararaca. And this was modeled in the laboratory. So there's a synthetic copy of it. And this is now taken by 100 million people worldwide, including myself. So I'm very grateful to the Brazilian jararaca. And I'm told, by the way, that in Brazilian Portuguese, jararaca means mother-in-law, but I think you better delete that from this thing, because I think that might be highly sensitive. So when you say that a snake is neurotoxic or hemotoxic or vascular toxic or myotoxic, it reflects these different actions of venoms. And as Bart said, the diversity of effects between different species of snakes from different genera reflects these extraordinary differences and complexities in venom composition.
So is there a single antidote that works for all of these, or do we have to produce specific antidotes for specific antivenoms?
Well, the traditional antidote, the only antidote available today specifically for snake venom, is antivenom, which is produced by immunizing a large animal like a horse or a sheep with increasing doses of selected venom, starting with tiny doses that won't kill the animal, building up and up. As the animal's immune system produces neutralizing antibodies against the venom, it will become more and more protected. So in the end, you will be giving it many times the lethal dose of venom, and it will tolerate it. And then at a certain point, you can harvest this plasma from the animal. I mean, it's all done very ethically. You know, the red cells are replaced, and the animal is not going to die of exsanguination. It's all done in a very controlled by veterinarians and so on. The product is a refined plasma rich in these neutralizing antibodies, and they're refined in various ways to purify them further. The level of refinement determines whether, as your unfortunate patient Albie suffers from serum sickness, a really bad attack of serum sickness, a reaction to the antivenom. This depends on the degree of refinement. And since it's not a commercially profitable drug in the way that ACE inhibitors are, for example, unfortunately, there isn't much competition amongst manufacturers to get into this market of antivenom production. So that's another reason for another sort of neglect that eventually bears on the fate of an unfortunate snakebite victim. But specificity, Albie, you're absolutely right. Because of the distinctive nature of the venoms of different snakes, it's extremely unlikely you could ever produce a universal remedy. But you could, clever science is producing more and more ideas, which I could summarize at some stage if anyone's interested, about for the future, about how we could progress from this now more than 100 years of anti-venom production, hyperimmune serum production in animals, progress from that with all its limitations and dangers to something perhaps more scientific, more targeted. But that, I'm afraid, is still a long way in the future. Although it's dominating the journals at the moment, these new ideas have a long way to go. They have to go through the process of human trials to confirm their safety as well as their effectiveness. But this specificity of venoms is what makes the whole thing so difficult, why you can't just give anti-venom unspecified wherever you are in the world to a snakebite victim.
And that is something I think that's important to point out, because we'll talk about snakebite management. Both of you are experts on that. But what I'm concerned about is that people get treated for snake bites that are totally innocuous. It's a dry bite from a potentially venomous animal, or it's not a venomous snake at all. And people get treated. We certainly see that in Africa. People get treated for snake bites with all kinds of weird and wonderful things, of which probably the most innocuous is the so-called snake stone, introduced by, I think, missionaries in many parts of Africa. We simply put a black stone with some magical powers on a snake bite wound, all the way through to treating people with high doses of adrenaline and cortisone in the absence of having any antivenom available, or antivenom is given that is completely inappropriate to the type of potential envenomation that occurred. And I think if we could, it would be very nice to give some guidelines to our colleagues and to the traveling public as to what do you do if you're bitten by a snake and you don't know the snake, or you think it's potentially venomous, and you're in a rural area and you end up at a little clinic and guys start coming to you with drips and needles and all kinds of potions. How do you get out of that situation?
Well, you asked so many different questions there, Albie, all of them very good ones, by the way. But I suppose it is important. How should you react if you're bitten by a snake, or even if you think you've been bitten by a snake? Because people can tread on a thorn at night and think, oh, that must be a snake bite. I think that all these real and suspected snake bites should be taken seriously straight away, because we know the potential for rapidly developing life-threatening consequences. And the whole point of first aid is that it's something you apply immediately, either yourself as the victim or a bystander. It's not something you wait several hours and have it at the hospital. First aid is for now. And that's why I'm now in favor of not going into some academic discussion, might it be venomous, which venomous snakes occur in this area, so and so. An unthinking, knee-jerk reaction. If you think you've been bitten by a snake or know you've been bitten by a snake, switch off your brain for a moment and apply first aid. And Bart and I can discuss later which forms of first aid are sufficiently effective and sufficiently safe and sufficiently practicable to recommend today. That is a key question. But whatever it is, first aid is applied immediately. So that's what you do. And then, of course, the next thing is to get medical help. And finding medical treatment may be a matter of days. In the case of some of my patients in South America, traveling by canoe and waiting for a lorry and all the rest of it, or it may be just an hour or two, something like that. And that is critical, getting to medical care as safely as possible without exercising the bitten part so that you're encouraging the venom to spread and become absorbed. That's the next crucial decision. And also not to do stupid things. And a lot of these have been mentioned already today. Making local incisions, trying to suck out the venom, applying an electric shock, applying a traditional remedy. And you can't blame people living in rural areas throughout the world from developing some faith in their local remedies. Almost any remedy for snakebite is going to work in a proportion of patients. You've given the answer yourself, Albie, because many, even if it is a snake bite, it could be a bite by a non-venomous snake, it could be a bite by a non-snake, a snake-looking animal like a lizard or an amphibian. It could be a venomous bite in which no venom is injected. This is the dry bite thing, which is such an important principle of clinical management of snake bite. The venomous snake bites. In fact, there are puncture marks, so the fangs have penetrated your skin, and yet no signs of envenoming develop. There's no evidence that any venom has been injected. Why on earth not? What a stupid snake. Surely, fancy biting and not injecting venom. That's still a mystery exactly why it happens. But in the case of one of the most important medical snake, medically the most important snake in Australia, the eastern brown, it's said to be up to 90% of bites are dry bites, bites without injection of venom, which is very, very convenient for Australians, because if you're one of the 10%, the eastern brown can produce very difficult early life-threatening effects. Anyway, that's why almost any remedy for snakebite will appear to work, and that's why so many of these sometimes ghastly things like incisions and electric shock and exploding gunpowder in the wound, or all these other things, applying very tight bands. You know, we've all come across so many of these, so many different plants that are absolutely specific for snakebite. I'm afraid they're all based on, well, this is my prejudice coming out, I apologize, based on lack of evidence and working on the basis that so many snake bites or so-called snake bites are not going to cause any threat to life anyway.
So can you speak to a little bit about the tourniquet? Because I know often that's kind of what's portrayed in a lot of TV and movies and media. So is the tourniquet in applying that effective and important before transferring someone to medical aid? Can you speak to that, Bart or David?
There are different levels of pressure with a tourniquet. So there's arterial tourniquets, which literally what saves lives in people who have a pulsating blood loss from a vessel that's been damaged, an arterial vessel. But there's also venous tourniquets, and then there are different methods of pressure, which I think that at some stage during this, we're going to discuss it further in relation to first aid. But taking a step back, the one thing that there's universal agreement about, and that is that immobilization is absolutely critical, because no matter what sort of pressure bandage you put on, if the person is not fully immobilized, then the experimental work that's been done shows that the bandage or even a venous tourniquet will not prevent the venom being absorbed. So immobilization is critical, and indeed stories of where complete immobilization without necessarily even bandages can be potentially life-saving, because eventually a lot of the venom components they are broken down in the body as well, so they don't persist forever. So immobilization becomes something that we need to emphasize. And in Australia, unfortunately, they used the term PIB for many years, which is called pressure immobilization bandages. And even today, some of our ambulance officers who are professionally trained will bring someone in with a bandage on, a pressure bandage, but they haven't splintered the limb. So we changed the terminology from PIB to PBI, which is pressure bandage with immobilization. And that was about 20 years ago, but still in Australia, the idea of immobilizing both the person and the bitten, and then the bitten limb with a splint, is not adequately followed in some circumstances. But as to what the type of pressure bandage or tourniquet or whatever is applied, that's something that we can come to when you're ready to discuss it. Yeah.
Could I just go back to Aisha's question, are tourniquets effective? Because as Bart has pointed out, the word tourniquet, it's slightly ambiguous. in my understanding, a tourniquet should really be an arterial tourniquet, a band that is applied sufficiently tightly to cut off the arterial blood supply to a limb. And this is a problem because arterial tourniquets for snakebite probably are effective. If you applied a tight arterial tourniquet, someone who'd had a mamba bite on their leg, for example, it's possible that would be effective in preventing spread of the mamba venom. But the reason why we've completely abandoned the idea of tourniquets, they may be effective, but they are not safe. The dangers of tourniquets are far more important than their perhaps theoretical benefits, because a tight tourniquet, as others have mentioned, if it really prevents arterial circulation to the limb, will result in gangrene. And anyone who's worked in tropical developing countries, as I have seen the horrible results of tight tourniquets applied for several hours. The patient comes in with a gangrenous limb fit only for amputation, And it's a horrible thing. That's why any suggestion of recommending tourniquets is completely out. And the ambivalence about whether you mean a venous tourniquet or a moderately tight band, I think we mustn't be confused about that. Tourniquets are out. But as Bart says, the principle of applying enough pressure to reduce lymphatic flow, this lymph system is parallel to the venous system in draining the tissues, but it tends to pick up larger molecules, including some of the venom toxins. If you can cut off the lymphatic drainage from the site of the bite where the venom has been injected, and also reduce the venous drainage from that area, then this is a sound basis for believing this might delay the ultimate spread of venom to cause life-threatening systemic envenoming. And the pioneer here really was Struan's Bart's countryman, Struan Sutherland, who in the 1975 or 6 was working on animal models, and he developed a system of pressure immobilization combining, he actually used, in experimental monkeys, he used an inflatable cuff and replaced in practice by crepe bandaging. And this was adopted in 1976 by the Australian authorities and is still the guideline. Now, Bart and his colleagues have done some excellent work on this, critical work showing that in practice, the Struan-Sutherland's method is not only difficult to teach people how to do properly, the pressure is so critical, but it's also impracticable because people don't have the necessary materials. Crepe bandage is useless. Bart's group show you need a really high quality, wide, elasticated bandage, the sort you use to treat lymphedema with. And as he said, the importance of immobilization, not only the pressure, but also the immobilization. But we can discuss more how this system, which is actually very demanding in equipment, particularly if you transfer yourself from Darwin or Melbourne to rural Africa, you can imagine the difficulty of assembling the necessary equipment to apply the Struan-Sutherland method and its later ramifications would be really prohibitive.
Okay, but if we're still in the bush, so to summarize maybe where we are is someone gets bitten or thinks they were bitten. The important thing is to immobilize the patient, immobilize the affected limb, and with including splinting it, so it's immobilizing by splinting, applying a pressure bandage, if you know how to do it correctly and you've got the right equipment, and then to get the person to hospital. Now, if you're the doctor in the hospital in a rural area, they didn't bring the snake along. Even if they did, you don't really know snakes. Is there any way to tell from a medical point of view, as the doctor, whether this is a likely envenomation or not? What are the signs or symptoms we're looking out for?
That's an excellent question. Can I just go back, because you said apply a pressure bandage, there is an alternative to pressure immobilization bandaging, or variants of the Struan-Sutherland method, and that is the pressure pad, which is also an Australian discovery, a different university in Melbourne, which was ignored for quite a long time. And although the evidence is not overwhelming, I would like to show you some evidence or discuss some evidence that I believe supports the use of a pressure pad. And this is vastly simpler than the pressure bandage, because it doesn't require any particular equipment, just a fist-sized lump of material that you apply directly over the wound. You apply pressure in the hope that you will be compressing the veins and the lymphatics draining that wound, and you apply it with a tight bandage of some sort. And immobilization is the essential additional thing for that method as well. This is far more practicable for the areas where snakebite is really a very common problem. These are not Western countries. These are countries that are greatly challenged to provide any equipment, and where arguably first aid is even more important, because the delay between bite and hospitalization will be longer.
I've actually got here some of the commercial things. I don't know whether you can see those. Can you see those all right? Yeah. So this is just one. It's called Premium Snakebite Kit with a whole lot of bandages. Here's another one, which it's all based on the same thing, Survival Kit. And then here's another one. These are all commercial, and these are all the bandages. And these bandages will, if they're now at least not the flimsy crepe bandages, they're now going to the elasticized bandages. So if you have enough of them, you will be able to retard venom absorption. But the thing is, you need enough of them for a big limb, for instance, if it's a bite on a thigh or a lower leg. So potentially having the pressure pad method with then subsequently some bandages over the top, which is what Sarah was going to ask me about, is potentially a way forward. But it's hard to change people's beliefs in things. And indeed, one of the questions we asked and got into trouble for about 20 years ago was, how many people do we think that the crepe bandages in Australia that were being basically in all the guidelines, how many lives have been saved by pressure immobilization bandages with crepe bandages? And the answer is probably not too many.
And there are some anecdotal cases, including published cases, where release of the pressure bandage was followed by a very rapid deterioration. I was involved in one of them near Adelaide, where a guy was bitten by this was a snake keeper, a venom producer, was struck on his trunk by a taipan, which is a pretty fearsome Australian snake. They applied, of course, you can't do a pressure immobilization bandage on your trunk, but they applied a pressure pad and wound it all around his body. So pressure was applied directly to the bite site, and he was rushed to the hospital and wasn't in bad condition when he arrived. They took off the bandage, and within minutes he deteriorated and had profound blood clotting problems and so on, and was becoming paralyzed. So, I mean, anecdotes like that, I think, confirm to me, perhaps not in a scientific way, a completely adequate scientific way, that this method does work. In the same way, my late friend Dr. Utung Pei in Burma showed that when he applied the pressure pad, the anchor method from Monash method, and measured blood venom levels while the pad was in place, there was no change. But once the pad was released, the levels really took off. And I think this is limited but very impressive data. And to be fair, Bart has been calling for ages, I think probably for 15, 20 years, for more research on this by countries like Australia that have the means to measure levels of venom antigens in the bloodstream. It's not an easy technique, but it can be done. This is very good objective evidence that a method is working if the blood levels are low while the method is applied and rise when the method is removed. But there's been very disappointing follow-up, Bart, to this. It clearly isn't exciting research. Much better to produce some new monoclonal antibody that's going to save the world.
If I could just add an anecdote from Africa to support what you've just described, a friend of mine who's now the CEO of a large hospital group but started off his life as an anaesthetist told me many years ago about a young man that was admitted with an alleged neurotoxic bite to a hospital just outside Johannesburg. And he was admitted with a pressure bandage. And because he was asymptomatic, he had a pressure bandage on his whole leg. Because he was asymptomatic, he was sort of put in hospital for observation overnight and nothing more. And then the next morning, the doctor did his rounds and walked past and said, okay, well, you're obviously fine. Take the bandage off. You can go home. And within minutes, the guy had to be put on a ventilator. And that's also absolutely anecdotal. But the guy I heard it from isn't, he's not telling a fireside story. This was coming from an anaesthetist that ran the ICU where this guy was being observed overnight and then next thing stopped breathing long after the bite and after the removal of the pressure bandage. So something to be looked into further. Further studies need to be done.
And when we looked at the clinical cases, such as the one that David mentioned, where they put some pressure over the site, and there were some others that were clearly people where they did have, like Albie described, a fairly rapid absorption of venom with systemic features, potentially life-threatening, after removal of the first aid. Those first aids that were being used to support the concept of the pressure immobilization bandage were actually not the type of bandages, when we actually looked into it, that were being promoted, which was the crepe bandages, the flimsy crepe, but were in fact, one of them was an Esmarch bandage that is used for, literally, you can use it for a venous tourniquet for giving anesthesia, or at least paralyzing or making numb a limb. The point being is that these were not crepe bandages. So I think that the pressure pad method and then the concept of what materials you're using are absolutely critical. But you also go back to the absolute imperative aspect of immobilization as well.
David and Bart, you both mentioned Myanmar, and so I was actually at the Myanmar-Thailand border at Ratchaburi with Dr. Anne McCarthy, actually, and we were there visiting a hospital. And in the emergency room, we went in, and this area is known as King Cobra territory, and a lot of Cobra territory. But we went into the emergency room, and next to the CPR codes on the wall in the emergency room, in the kind of the trauma bay, was this huge board of models of snakes with the different types of snakes. And I guess with snake bites being so common in this area, they would ask patients coming in who'd been envenomed or bit that, which snake bit you. So my question is, how important is it to be able to identify what bit you? Should you be bringing in the snake? Should you be trying to chase after the snake? Should you be trying to take a photo of it? Like, what would you recommend if somebody is bit in that regard once they reach, I think I was bit by this particular snake?
If it's being killed or if it's alive, we do not encourage people to kill a snake for the reasons David said. But the reality is worldwide that snakes that have bitten people are often killed. And then a picture can be taken, or the dead snake will often come in, as happens here in Darwin with the patient. And so there are keys to identifying the snake, and that can be incredibly helpful. However, the first thing is that the snake that bit the person? And that is always the question that we ask the remote doctor who is ringing us in the middle of the night saying that we have a snake that have a person bitten by a snake, and we have the snake that bit the person, and will you send a plane out to evacuate this person? And it may be a 2-hour plane flight, several more than 1,000 kilometers to go and retrieve that person back to hospital, which we have to do, and we have the resources in Australia to do. And it will be the snake. But if we're not sure that it is the snake, then it can be very dangerous to attribute the bite to a snake that is non-venomous when in fact they are bitten by a venomous snake. And we've had that happen on a small number of occasions. So we always try and have that chain of custody of the creature to make sure it was the snake that bit the person. When we have algorithms with our processors in the Northern Territory of the pictures that we need of the dead snake, and there are 4 pictures that we need, which look at the scales around the eye, look at the scales around the cloaca, which is the anus of the snake, and then pictures of the mid-body scale. So these 4 pictures can help us identify whether it's a venomous or non-venomous snake, if it is the snake that bit the person. And we've been able to save having to send planes out to remote communities on quite a few occasions, because it's definitely a non-venomous snake. But you have to have certainty about the snakes in your area and the expertise. And I have colleagues who can help me identify the pictures that are sent in. And then when a snake is brought in, if it's a dead snake, we can also identify that snake. And it is incredibly helpful to be able to do that. But if you don't have the snake, then you are relying on the clinical algorithms or the syndromic natures that happen with that particular type of snake in that area. So it is, you do need people who are able to make that clinical assessment of the person after you've had a look at if you have the person in the hospital, but you don't know what snake's bitten them.
But David mentioned something about diagnosis, and I think he was referring to venom detection kits in Australia. Did you want to brag about what we can do in terms of diagnosis?
Well, I'm unfortunately, David, now an outlier in Australia in that we use the venom detection kits in Darwin, but we only use them where we have someone envenomed to see whether their clinical syndrome is consistent with what we find on the venom detection kit. You may not be aware, David, but the national guidelines that are now published in Australia from my southern colleagues say that the venom detection kit should no longer be used in Australia. And the company that make it are, I would think, almost certainly going to take it off the market, because in the majority of Australia now, including the official guidance from Queensland Health, is that venom detection kits are not to be used. We still have supplies in Darwin because we know how to use them properly, and they are incredibly helpful. That's how we've been able to diagnose our last 4 taipan bites. But what's happening now in Australia is that there's a move by the toxinologists who are providing the advice to go to polyvalent antivenom or brown snake antivenom, and not try and attempt to make a diagnosis of the genus or the species of snake. So Australia is going to lose its expertise in understanding the syndromes that are occurring with different snakes, because we have our common species, but there are also some very interesting snakes out there which are behaving in slightly different ways, which are occasionally highly venomous, and for which more work needs to be done. So Australia, unfortunately, Sarah, is being dominated by what those of us in rural Australia are calling the geographic narcissism of various people in the cities, saying that we should not be using venom detection kits.
Well, I think that's very bad news. And of course, like any test, you've got to use it intelligently. And the problem with the venom detection kit, it was on some occasions you could detect venom on the skin because it's based on a skin swab in a patient who was not envenomed. You know, the snake had left a bit of venom on the skin but hadn't actually injected it. So Bart's point that he uses it in envenomed patients to either exclude or support a species diagnosis, I think this was a great strength of Australian toxinology. And for all its limitations, I think the VDK was an absolute world leader, and I'm extremely disappointed to hear that. And the trouble about toxinologists, we're just human, and I'm afraid there are human foibles, there are human petty ambitions being exercised here. In almost every country, you will find a strong difference of opinion about the basics of snakebite management. Because of as Bart says, these narcissists. So I think that's very unfortunate, Bart. And
I wasn't talking about individuals there, David. I was talking about geographic narcissism, and that is the belief that the overwhelming body of knowledge is in one of the urban mega cities of Australia, which consists of only two, which is Sydney and Melbourne.
Yeah, well,
Anyway,
I was talking not about geographical narcissism. I was talking about individual narcissism within Australia.
Dear.
Dear
I think
Professor Warrell, that's
Could
why
we?
you spent your life in Thailand. You are not being politically correct. You will not be allowed back into the United Kingdom, but I love it. Shooting from the
and
hip.
I
Very
would
good.
like to return to Albie's very good question, because this is an absolute key. What do you do as a healthcare worker when you receive a patient who claims to have been bitten by a snake, who's had first aid or not, and probably very frightened, because that is the overwhelming response I see in patients bitten by snakes. They've all been brought up with the idea that snakebite equals sudden death, probably sudden agonizing death, happening very quickly. So, there are some basic things like reassurance and so on, and taking an old-fashioned chronological history. When did it happen? How did it happen? With circumstances? All these are detective clues that will help you towards management. And I don't want this to get too sophisticated, because I know you're dealing with perhaps health workers, peripheral health workers, not semi-sophisticated doctors. But the key question really is, are there any signs of envenoming? Are there any signs that venom has been injected? Because that is the key thing. The patient might have been bitten by a non-snake, by a thorn, by a non-venomous snake, or by a venomous snake, a dry bite. The key thing is there any evidence of envenoming? And you should make a judgment immediately, but don't leave it there, because envenoming can involve over many hours. In fact, there's a famous case from South Africa of a boomslang bite that didn't develop any blood clotting abnormalities for 48 hours after the bite. And then it came on really badly, a life-threatening envenoming. So at the first stop, when the patient is admitted, examine them very carefully. And that requires some clinical skills, not just the bitten limb, although that's very important. Is there any local swelling, tenderness, redness? Are any of the local lymph glands draining the bite site tender and enlarged? Are there lymphangitic lines up there? This sort of stuff. But then systemically, clearly the vitals, the blood pressure, not just supine blood pressure. Does the blood pressure fall when the patient sits up? Because many snake bites, for example, puff adder bites in South Africa, one of the key features is early evolving hypovolemia, resulting from leakage of circulating volume into the bitten limb. And check the blood clotting. There are simple tests you can do at the bedside to see if the blood is clotting, but look at the patient for signs of bleeding, the clinically useful signs, the gums, the nose, perhaps the urine, early signs of spontaneous bleeding, and signs of neurotoxicity, not just a casual glance at the patient, clearly paralyzed because the eyes are half closed. Is it paralysis or just sleepiness? Do a formal test of early signs of paralysis. Anyway, I'm sorry, I'm going on a bit, but that's the trouble. You must allow old men to prevaricate a bit. But the principle of clinical medicine, of clinical assessment, will determine the answer to your question, Albie. Are the signs suggestive of either very severe, rapidly progressive, or systemic envenoming? In that case, you'll have to think about antivenom. Otherwise, the patient still needs treatment. They need reassurance. A booster shot of toxoid, intramuscular tetanus toxoid, is great. It's great placebo. It's also highly relevant for any penetrating injury. So reassurance, and then observation, I think, for a minimum of 24 hours. And I'm laughed out of court in some busy Indian hospitals. We haven't got room to keep all our snakebite patients lying around for 24 hours. But I think that's a reasonable compromise if you have the facilities. And watch what happens. The last patient who died of adder bite in England, a boy up in Scotland, was left unobserved overnight, and his blood pressure drained away, and he died early the next morning. Absolutely disgraceful, lack of basic clinical monitoring. I think
So
I've
I
said
think
enough.
no, that's fantastic, David. I think Albie, the principles of observation and the things that you should be looking for are the same worldwide for snakebite. There will be differences, but the first thing, it starts at the site of the potential bite, which may not be from a snake. And are there marks? You can't rely on the fact that there might be two puncture marks of fangs, but are there marks? Is there swelling? Is it worse than that, with more than swelling, with bleeding? And in Australia, it's uncommon to have, and New Guinea, it's uncommon to have a lot of local reaction, whereas in some parts of the world, that's the main cause of death, is the local tissue damage and secondary infection around the bite. But in Australia, we've had, or in New Guinea, there were deaths from taipan envenoming where we could not find, in children, where we could not find the fang marks of the taipan. And that was, each of those was a tragedy. The things that correlate with snakebite where I am is basically alcohol, tattoos, and being toothless. So that correlates with snakebite where we are, because those are the people, and being a male, they're going to pick up the snake. So the thing is that you can be both intoxicated and envenomed, but you can also be nauseated and have abdominal pain, and you've not even been bitten by a venomous snake. So it's non-specific. And then there are the things that kill people, exactly as David said. There's a coagulopathy, in other words, the problem with unclotted blood and bleeding into the brain being the end result that will kill people. And of our last 6 deaths in the Northern Territory, 4 of them have been fatal intracranial hemorrhages from brown snakes. One of them was the tragedy in 2018 that David helped us identify, the sea snake that killed a British backpacker who was working on a prawn trawler.
So we've heard a lot about what snakes can do to you and some of the symptoms and signs to look out for in patients. But I guess this podcast is really focusing on travellers and how much of a problem is snakebite in travellers. I mean, globally, the data's pretty limited. There's been a study of animal exposures amongst travellers attending geosentinel clinics over a 12-year period, where it just included 18 reports of snake bites, including in travellers to Nepal, India, Indonesia, Thailand, Malaysia, Sri Lanka, and Zambia. However, it's important to note that geosentinel data might not reflect the true scope of the issue, because most geosentinel sites are in high-income countries and urban settings, whereas, as we've heard, snake bites are more common in lower resource countries and remote areas. So how big a problem are snake bites for travellers?
Well, it pales into insignificance in comparison to the numbers of deaths worldwide from snakebite, which David may want to quickly summarize in the different parts of the world. But I would just say that of our 6 deaths in the Territory, Northern Territory of Australia, over the last 20 years, we've only had 6 deaths. So we're very fortunate. And it's just not the issue it is in so many other parts of the world. But of our last 6 deaths, 2 were actually in travellers. There was the tragedy, as I mentioned, in 2018 of the British backpacker who was working on a prawn trawler, killed by died after handling a sea snake, and David helped us identify the potential sea snake with there. And that's only the second sea snake death in Australia in the last 150 years. And the other one happened 100 years ago in the Northern Territory as well. The other death we had was in a tourist from southern states coming up to go camping in the remote part of the Northern Territory, who died after being bitten by a brown snake. And that tourist died at the ranger station, where there was no first aid available apart from immobilizing, and basically had, unfortunately, an arrest in front of the ranger, while a number of people, including me, were on the phone talking to the ranger, and he was unresuscitatable in this remote part of the Northern Territory. So that's they're the 2 very rare scenarios, but 2 out of our 6 deaths have been tourists. But David may want to, I'd really like to hear from David a very quick summary of the deaths globally that are happening in local populations.
Well, as Bart has said, there is this incredible disparity between the risk to travellers, which is tiny, but I think dominates their imagination more than the real risk. So many travellers have told me how their their trip was ruined by anxiety about snake bite or scorpion sting or spider bites or something else, jellyfish stings. Their risk is tiny, and over the last few decades, I've accumulated only about a dozen cases of travellers from UK being bitten by snakes. I might just mention one in particular. A 30-year-old woman who was an ambulance worker from Britain was hiking in the Grand Canyon, and she was walking last but one in the queue of people walking along this track, and was struck on the calf by a snake that she thought looked greyish, and it rattled, so it was definitely a rattlesnake. And within half an hour, she'd collapsed, couldn't keep conscious if she sat up. Being the United States, the rescue was fantastic. She was lifted off by a helicopter and taken to one of the hospitals at the rim of the Grand Canyon. So that side of it was good. Not so good. They resuscitated her by giving her 1 vial of antivenom into each thigh. An intramuscular administration of antivenom is not effective. It's much less effective than intravenous. But anyway, she had rather a difficult time, but she survived and consulted me when she finally got back to UK because of shooting pains, sciatica-like pains in the bitten limb and anxiety. And I was able to reassure her and to recommend some vigorous rehabilitation, which seemed to do the trick. So that's just one of the very few only a dozen, I say, and many of them were much higher risk. One was a snake photographer in South America, and so he was probably asking for it. But for ordinary tourists, it's extremely uncommon. I say the contrast with the risk to rural populations in many tropical countries is very stark indeed. The best data on snakebite from one of these areas comes from India, a very well-designed study, part of the Million Death Study, which has been going on for several decades now, which has covered all manner of diseases. I persuaded them to include some questions on snakebite, and the result of this was the extraordinary figure of an average of 58,000 snakebite deaths each year in India, a really astonishing number. And the breakdown of that figure was pretty horrific as well, because the highest risk group were young children between about the age of 8 and 14. And many of the deaths occurred outside hospital. That's why they hadn't been reported to the official data in India. Declared a far lower number, just a few thousand each year. Many people were dying outside hospital in rural areas. So this is the stark comparison. 58,000 deaths a year in India. We haven't had a death from a traveller being bitten by a snake in UK, as far as I know, but these data aren't complete, but that I've heard of. So that's the difference. But the perception of risk and the fear of snakebite is definitely there and can ruin enjoyment. And the positive thing is educating travellers about how to reduce the risk of bites. They can't remove the risk entirely if they're going to a snake-infested area, particularly if they're doing something heroic like collecting orchids in the Amazon or something like that, that involves going into the undergrowth. But reducing risk in sensible ways like good footwear. By the way, my unfortunate patient in the Grand Canyon, she was struck just above her boot. So it shows that even if you're wearing proper footwear, you can be unlucky. But sensible wear, socks, long trousers or pants or whatever you call them, and solid shoes. And as has been mentioned already, after dark is dangerous because a lot of species of snakes are nocturnal. They do their hunting after dark. And it's important to see them. So to have a light, some sort of flashlight or torch, and a prodding stick is very useful. And any lights outside the building, so beware of that. Safe sleeping is very important in South Asia, where there are crates that creep into people's dwellings at night in pursuit of their prey. And if the sleeping person rolls over and traps them, they will be bitten. And there's been a horrific video taken in Bangladesh, which went viral. I don't know if any of you have seen it, of a CCTV in a dormitory in Bangladesh. You can actually see this crate creeping in, and it fatally bit and envenomed 2 of the sleeping students in this hostel, making the point that safe sleeping, a raised bed, as someone showed already, or I think it was on one of the YouTubes that you circulated, a raised bed and tucking the mosquito net well underneath your sleeping mat. Even if you have to sleep on the ground or choose to sleep on the ground, you can still be safe if you tuck in your mosquito net. And of course, that's protecting you from other nocturnal nasties as well.
Does it have to be insecticide impregnated?
It's not so important as for protecting against the vectors, because of course the insect vectors, even if you have a few holes in your mosquito net, if it's insecticide impregnated, you've still got a chance of repelling them, even if you can't exclude them. But these common sense things, this is what you should I believe this is how you should reassure travellers. And you should also reassure them the basics. So many snake bites are not associated with any problem at all. Most snake bite deaths occur after many hours or even days. So there's plenty of time for medical treatment, for evacuation and so on. Effective treatments are widely available. And despite our rather disparaging remarks, the level of education of health workers, I think, has improved enormously over the last few years. Snakebite is suddenly in everyone's vision, thanks to the WHO's recognition of snakebite as a neglected tropical disease in 2016, greatest neglected disease problem that no one's ever heard of. So things are improving, but that would be my attitude to travellers. Certainly address even the unspoken fear, even if they don't tell you they're frightened. They probably are. How to reduce the risks of bite, and what to do if they were unfortunate, they or a companion was unfortunate enough to be bitten.
Well, thank you so much, Professor Warrell and Professor Currie, for joining us today. I know this is a huge issue around the world, and I think it's important that on this podcast and as travel health practitioners, we take a moment to really try to shed some light and spotlight this really horrific disease burden around the world, and for this neglected tropical disease, as Professor Warrell mentioned. And it does also weigh on the minds of travelers, even though the risk is small. But I think it's a good way to kind of approach the anxiety that a lot of travelers can have around it as well. And so with that, we're going to wrap up this episode. So thank you again to our guests, Professor Warrell and Professor Currie, for joining us on this really fantastic episode of the Travel Unravelled. I had to do it. And of course, to our expert hosts, Dr. Albie de Frey and Dr. Sarah McGuinness. This will be the first in our series on what we call creepy crawly critters around the world. Look to our future episodes on marine toxins from wildlife like jellyfish, and perhaps Dr. Currie can let us know how he has a jellyfish named after himself on one of those episodes. And of course, on other insect and arachnid bites, just spiders and scorpions and even caterpillars. As always, we've included all the links we've mentioned on today's episode in the podcast description. If you like this episode, don't forget to subscribe and let us know your thoughts. We love hearing from our listeners. And lastly, share this episode with friends or families who's about to board a flight, or that snakes on a plane, or planning any other trips. So thank you again to all our listeners, and we'll see you in our next episode.
Thank you.
Thanks, Aisha. Thanks, Prof. Thanks, Doc.
So that's a wrap for this episode. Thank you to our sponsor, the International Association for Medical Assistance to Travelers, located on the web at iamat.org. Don't forget to follow Travel Unravelled on Spotify and on Apple Podcasts or on your favorite podcast platform. We'll post fun clips and extra resources on the ISTM website located at learning.istm.org/podcast. We're also on Facebook, LinkedIn, X, and Instagram at _ISTM_. Travel Unravelled is brought to you by the International Society of Travel Medicine. Finally, and thankfully, Travel Unravelled is produced by Ghost Bureau out of Toronto at ghostbureau.com.
Please remember that the information presented in this podcast is intended for educational and informational purposes only. It should not be considered medical advice, nor is it intended to replace consultation with a qualified healthcare professional. The views expressed by the hosts and guests of this podcast are their own and do not necessarily reflect the opinions or policies of the ISTM or any medical or other health professionals, hospitals, clinics, or healthcare facilities. While we strive to provide accurate and up-to-date information, the medical field is constantly evolving, and there may be new findings or developments not included in our content. We encourage our listeners to consult with their healthcare providers for any medical concerns or before starting any new treatment. Neither the ISTM nor any of its affiliates, sponsors, producers, hosts, or guests are liable for any direct, incidental, consequential, indirect, or punitive damages arising out of access to, use of, or inability to use the content of this podcast, or any errors or omissions in the content hereof. By listening to this podcast, you agree not to use this information as a substitute for, nor does it replace professional medical advice, diagnosis, or treatment. Always consult with your healthcare providers for guidance appropriate to your specific health situation. Thank you for listening to Travel Unravelled. We are committed to sharing knowledge and fostering discussion in the pursuit of better health and well-being.